So we recently launched a trial here at the National Cancer Institute in collaboration with our molecular imaging colleagues. We are going to prospectively monitor patients with PSMA scans in the setting of early recurrence after definitive surgery or radiation, or what is commonly called biochemical recurrent prostate cancer. So this is a setting where for years we followed these patients and they had rising PSAs. And there have been multiple trials done in this population with ADT and even ADT and chemotherapy that have not demonstrated a benefit in overall survival. And what has happened in recent years is that with the advent of PSMA imaging and its approvals recently, there's a lot of more frequently these patients are getting imaged appropriately on the indication. And these imaging studies are finding essentially microscopic, or I would say clinically insignificant disease that was likely there for many years in a lot of these patients. So what I mean by clinically insignificant is we're taking patients who have negative CT and technetium bone scans and finding 2 millimeter lymph nodes, which years ago we never would have treated. And in the trials that were done, those treatments didn't improve survival. But it's unfortunate, maybe semantics or lack of, a thorough understanding of the differences between these imaging modalities. But it's unfortunate because oftentimes these patients are becoming labeled as metastatic and getting ADT for life and perhaps intensification with anti-androgens or chemotherapy. And the truth is, we don't really understand what the natural history is of patients with early recurrent prostate cancer, or even any recurrent prostate cancer after surgery or radiation, who have PSMA findings. And the presumption that they're equivalent to CAT scan or bone scan findings, which are really the main criteria and the basis and rationale for therapies that are ADT based, is unknown. And so what we're going to do is a trial where we're just going to monitor patients who have recurrent disease and get PSMA scans every 6 months. So we can gather this data and hopefully demonstrate that many of these patients don't need therapy. And we know this because not only is there negative trials from interventions in this population going back before the PSMA era a few years ago, but also because there's very good literature at Johns Hopkins that was accrued around the turn of the century and published about 10 or 12 years ago by Dr. Antenarakis and his colleagues that highlighted that patients with recurrent prostate cancer, especially if they have doubling times beyond 6 or 9 months, they can perhaps go 5 or 10 years without finding on a CAT scan or a bone scan. And it's very unlikely that these PSMA findings are going to lead to clinically symptomatic disease or I would say clinically significant disease. So it's unfortunate because we're creating a lead time bias by intervening on these patients and adding potentially quartiles of decades of extra therapy and the associated toxicities. And the other thing that I think I'll say is that while interventions with things like SBRT or other things are, impactful in terms of delaying progression, they're not curative because it's likely the PSMA scan is still not showing us all the recurrent disease. So again, this trial is accruing at the National Cancer Institute. Because of the way we're set up here, we're allowed to fly people in from around the country to do this imaging every 6 months. They can get PSAs at home every 3 months as part of the protocol. The trial actually doesn't take you off if you get interventions that are not systemic therapies beyond 6 months. So if you come here, we'll get you a PSMA scan. You want to take it home and your local radiation doctor wants to radiate you, that's fine. It's allowed on the protocol. You're still on the trial and we'll continue to get scans on you. Similarly, if patients got short course intermittent androgen deprivation therapy for less than 6 months, they would also be allowed to remain on the trial. So I think this is a very valuable trial that could fill a void in the data that exists right now. Many trials are ongoing in this population, but they're not necessarily always controlled by an arm, or actually, I don't know of any of these studies that are controlled by an arm that does not have any intervention. So there's always this presumption of benefit. And so it'll be interesting to see what our data shows about that relative to the other studies that are ongoing. And then as part of this trial as well, we will be capturing or collecting blood work on these patients for some biobanking and biomarker analysis to see if there's added things we could look at that help us better understand which patients may have clinically relevant disease sooner. And this trial will allow us to follow patients for up to 5 years.